You are watching Radicon.
The next case, comparing the right side with the left side, you can see an exophytic lesion, or you can say a polypoidal lesion, ossified lesion arising from the left iliac crest. Again, it's at the margin, so it's quite obvious, but you have to make a habit of looking at the margins of the image, and then you can see the CT demonstrates it's an exophytic lesion with corticomedullary continuity. It's an osteochondroma. In contrast, we come to the next case. You see a large expansile lesion, which is arising from the anterior aspect of the right iliac crest, extending into the acetabular roof, and then the extraosseous soft tissue or extraosseous component is like shell-like. I mean, one can say this could be a surface ABC because ABC can be aggressive, but one would be worried that this is some kind of a sarcoma with this kind of aggressive-looking appearance, mixed lytic and sclerotic. When you look at the iliac crest, it's quite heterogeneous. So there has been, it looks like an infiltrative process. This patient had an MRI, and the MRI shows a lobular hyperintense lesion arising from the iliac crest and extending interiorly. This is a chondrosarcoma, and a high-grade chondrosarcoma, unless proven otherwise. So think about sarcomas, Ewing's in kids, but in adults, flat bones, think about chondrosarcoma. ABC and metastases will be in the differential as well. Not in this case ABC, because there are no typical findings of ABC on the MR, but ABC can look, if it's on the surface, can look like shell-like expansile lesion, but usually without much osseous destruction, like in this case. Okay. Next case. So we looked at the iliac blades, sacrum, looks fine. Then suddenly your eye catches this abnormality in the right acetabulum. And then another, if you ask for another view, then it becomes more obvious. So there is a large lytic subarticular lesion in the right acetabulum. Again, subarticular lytic lesion, you have to think about GCT, but it could be metastases or myeloma. In this case, it was biopsied, came back as adenocarcinoma, but we didn't find the primary. So it's a metastasis of an occult primary. So think about the acetabulum. Okay. In contrast, this radiograph demonstrates a diffuse sclerotic abnormality affecting the left iliac blade, the iliopectineal line, as well as the ischial ramus. So this is a typical appearance of, you can think about post-radiotherapy change or sclerotic metastases, but with that kind of diffuse sclerotic appearance involving the whole bone, yes, you have to think about Paget's disease. This is a more gross example. So remember to review the iliopectineal line, and if there's any asymmetry, there's some expansion, some sclerosis, think about Paget's disease. Right, moving on. So the hip joints, on this plain radiograph of an adult patient, you can see that there is marked sclerosis and fragmentation of the right femoral head with complete obliteration of the superior and medial hip joint space on the right. So this is a typical finding, typical appearance of advanced avascular necrosis. But if you ask for a previous film, the previous film is 6 months ago. I mean, you can see that in 6 months ago, things were much different. There is mild joint space loss on the right side, but no definite features of AVN. And AVN usually progresses quite quickly. But when there is a progression within months, you have to think about underlying infection. So think about AVN when there is marked kind of destruction of one joint of the femoral head, but also don't forget inflammatory or septic arthritis. This patient had a steroid injection for pain, and then subsequently she developed this accelerated AVN.
This video is presented in collaboration with Radicon Institute of Radiology. You are welcome to subscribe to our YouTube channel and click on the notification bell for updates. For more modules in radiology CMEs, please visit our website www.radicon.org.